a look and just see whether you can open it?
I've seen. I can.
Oh, okay, brilliant. Thank you.
Yeah. So I've had a look. Yeah.
It's just that I couldn't do it on my Mac and I had to go on Windows to do it. I'm not even sure that works, but I'm glad it works. Thank you.
Good morning, Al. How are you?
Hi, Adele. How are you? Thank you so much for
I'm
joining
good.
us. We're so grateful. We just have participants joining. So we have about
That's
5 more
true, yeah.
minutes. And people coming in. I'm so grateful and we're so honored to have you with us.
It's my pleasure. Thank you so much. So I look just to make sure, and when I have such presentation with a group who kind of learner rather than just a presentation, like to have it interactive.
Yeah,
but I know that you have a system where I talk, then pause for a question. But I'm happy if any of them stop me at any slide and say, I have a question here, or can you clarify this one more time? I'm absolutely fine with that. Even from the title, anyone can stop me at any time.
That's really humble. We're so grateful. And it's your baby, Adele. So very happy to run it as you feel you can. So there's no fixed way of doing it. We've obviously got participants who kind of are very enthusiastic because this is something that's new and upcoming, and they're doing very well. I think the entire group, I've just kind of done and seen and gone through a lot of their logbooks yesterday. So everybody has kind of done very, very well so far. So I'm hoping that, there's, How is the weather in Toronto at the moment?
Cold.
Oh dear.
Okay. I shovel 30 centimeters on Saturday of snow. Took from me from the morning to the noonish time just to clear the driveway.
Sure. I dare not tell you what the weather is like over here because I will upset you. It's 26 degrees.
I know. This is a lovely time of the year. Yeah, enjoy.
Yeah, the weekend we had one of our Indian festivals, which we call Holi, and I mean it was absolutely jam-packed. Really nice weather. Yeah.
Yeah. This is good. Yeah.
So just gonna start.
How many expect in this session?
So 20.
20.
Yeah, we have a total of 25. So usually plus minus 5.
Okay.
Most of my colleagues from India usually trickle in just a few minutes late. There's a concept that we call in India Indian Standard Time. And often you'll find they're either just dot on the clock or...
Yeah. Like time plus.
All of our UK participants have actually joined. So, yeah. So, folks, if I can ask you all just to give an introduction to Adele, just one by one, while we're waiting for the other colleagues to join in. So, Shankar, would you like to just give an introduction? Just say where you're from and what you do. Shankar, you mute. Yeah.
Sorry. I'm Shankar Narayanan. I'm a consultant neonatologist. Work at Watford General Hospital, which is a level 2 neonatal unit in Northwest London area. Thank you.
Nice to meet you, Sean.
Kirti?
Hi, I'm working as a clinical fellow at a NICU in University College London Hospital.
We've got Naz.
Hi, I'm Naz Merchant. I'm a consultant neonatologist at Watford. I work with Shankar, and it's been great to be on this focus course. Thank you. I'm also multitasking. Sorry, I'm going to pick up my son. Thank you.
Understandably.
Anna.
Hi, I'm Ana. I work at Lisbon, at Cascais, no Lisbon, in Portugal, in a NICU of an hospital level 2. And it has been a pleasure to be in this course. I really love it. Thank you.
Doris, would you just like to give a little intro?
Hi, can you hear me?
Yep.
All right. So hi, good afternoon from the UK. My name is Doris Yamabo. I'm a neonatal consultant at the Luton and Dunstable Hospital in the UK. It's one of the 3 level 3 hospitals in the east of England, in the UK. And honestly, doing this course has just been amazing and insightful. It's honestly changed my practice in huge ways. So I'm really, really happy for this opportunity. Thank you.
Dr. Vetravel, would you like to just introduce yourself, sir? Might not be hearing us. Dr. Didier, Dr. Mengwa, would you just like to give an introduction? Just.
Hi, I'm Dr. Didier. I'm a cardiologist in Mexico City.
So Didier is a pediatric cardiologist from Mexico City who's very interested in learning lung ultrasound as well. Dr. Hassoun?
Yes, Mohammed Hassoun, consultant neonatology. I'm working in Kuwait in Royal Bahrain Hospital, level 3 unit. Really, we enjoy this course. Thank you very much for all the participants and the speakers.
Dr. Leila?
Hi, Dr. Leila Obeid. I am a consultant neonatologist at Corniche Hospital. I work with Dr. Alok. Nice meeting you all.
Thank you so much. Sujit, would you like to just introduce yourself?
Hi, Adela. Hi, I'm Sujit Pereira. I'm one of the neonatal consultants based at Tertiary Neonatal Unit in London. Pleasure to be here.
Thank you so much. And then I've got Dr. Rana. Dr. Rana, would you just like to introduce yourself?
Hi, I'm Rana Alia. I'm a neonatal consultant in health teaching hospitals in north of England.
Thank you, Dr. Rana. I'm so grateful.
Thank you.
I've got Dr. Sharif. Dr. Sharif, would you like to introduce yourself? You're muted, Dr. Sharif. Sorry.
Can you hear me now?
Yes, yes, yeah.
Hi, I'm Sharif. I'm one of the neonatal consultants working at St. Peter's Hospital, which is a level 3 hospital in the UK. Thank you very much for this very useful course that really changed our practice.
I've got Dr. Maria. Maria, we're just doing a round of introductions. Are you able to introduce yourself? I see you don't have a mic. If not, just type in. And Subhash, would you like to introduce yourself? I think Subhash might also not have access to mic. So I'm going to start so that we allow Dr. Adel to present, but just to give you a little bit of a flavor. So Adel works as an assistant professor of pediatrics in Toronto at the Mount Sinai Hospital. He has and is director of point of care ultrasound in Mount Sinai Hospital for neonates. He's done a huge amount of work, and he works very closely with the NeoPOCUS group, who themselves have also done a huge amount of work in being able to actually train using ultrasound. setting up point of care programs. I think the one thing that I would humbly acknowledge is that our Canadian colleagues are probably, I'd say, decades ahead of us in terms of their ability to kind of establish training programs, a curriculum, and being able to kind of establish what I would say are clinician groups who are able to use point of care ultrasound in a structured, evidence-based way. So it's an honor to have Adel here with us, and I will pass on to him now. God bless you, Adel. Thank you.
Thank you so much, Alok, for the invitation and for the course. And I'm enjoying the course too. Like, I have a quick glance through some of the sessions, which is very interesting. And I saw some of the participant imaging for the lung ultrasound, which is actually great. And the discussion was excellent. As Alok said, like I do a lot of lung ultrasound, but also at the same time, I have interest in studying the diaphragm. Using the bedside ultrasound too. I believe this is the first presentation for the group. So now start the recording. I'll be serious now.
Okay, that's all right.
Yeah, so I was saying that along with the lung ultrasound, I'm interested to study the diaphragm. Has lots of contribution, the same as you heard about lung ultrasound and how it can inform our clinical decision. The same for the diaphragm too. It helps you, especially if you have a baby on mechanical ventilation or a baby post-surgery, and you need to know how efficient the diaphragm is working. As you know, there is multiple ways of assessing the diaphragms, not only ultrasound, but for this session, we'll focus on using the bedside ultrasound to assess the diaphragmatic function. So I have nothing to disclose. My objective today is to discuss with you first I will start with some anatomy and function for the diaphragm. Then we'll go over the technique, how we can perform diaphragm ultrasound, and what are the indices, what you will be using to report your diaphragm function. And then we'll conclude with some literature review to see what's the evidence outside of using or utilizing the ultrasound to assess the diaphragm, not only in neonates, but I might share some adult literature too, because as you know, for lung ultrasound and diaphragm, adults actually are the leading group, and we are learning a lot from them. So I always suggest that when you do your search, don't limit your search for neonatal, but add also pediatric and adult. They have lots of stuff to add to our knowledge. So as you know, the diaphragm is the principal muscle for respiration. You can count on the diaphragm around 80% of the inspiratory effort. And this function of the diaphragm was found to have contributed to difficult weaning of ventilation, or actually prolong the duration of ventilation if the diaphragm is not functioning very well. The sonographic evaluation of diaphragm is not an old topic, so it's a recent one, and it's gaining more and more popularity in the NICU as a non-invasive technique to assess the readiness of our babies for extubation. The structure of the diaphragm, and I'm talking very, very brief because this is just introduction to our ultrasound assessment of the diaphragm. Diaphragm is formed of 4 parts. So the middle central part is called the transverse septum. And you have the 2 on both sides, the right and left pleuroperitoneal folds. Then you have in the center what we call the esophageal mesentery, where it has the holes for the esophagus, for the descending aorta and other structure. And more important, I will say the periphery part of the diaphragm that's attached to the chest wall, that we call it the muscular body of the diaphragm. So this is the 4 parts of the diaphragm. I need you to focus on this part because we will talk a lot about this part of the diaphragm, the area of opposition, which is the muscular part of the diaphragm that start to be attached to the chest wall. And this is important for our assessment of the diaphragmatic function, alongside with the diaphragm dome or copula of the diaphragm. So this is the two parts that we're going to talk about and discuss how we can assess the function of this part, the dome of the diaphragm, and the muscular part or the area of opposition that's attached to the chest wall. So regarding the function of the diaphragm, I like to summarize it as this is the piston. It works like a piston that with the movement up and down, it helps with decrease the or increase actually the negativity or negative pressure inside the thorax that help with the inhalation and increase the lung volume. And when the diaphragm goes back, it increases the pressure inside the chest and lead to exhalation of the air outside the chest. To work, the simple way is to consider it like a piston. I'm going to fix this one just for a second. Yeah. So what's the indices for assessing the diaphragm using the ultrasound? This slide is a little bit busy, but it represents almost like 80% of the whole presentation in one. So you have this holistic picture, then we'll go piece by piece and explain each part. So we can assess the function of the diaphragm in two ways, what we call the qualitative way. Sorry, this should be the quantitative. It's like a typo issue. So there is the quantitative a way of assessing the diaphragm, which is divided into two parts, assessing the thickness of the diaphragm. And here I'm talking about the diaphragm thickness during inspiration, diaphragm thickness during expiration. Then with the assistance of a formula, will calculate the diaphragmatic thickness fraction. And the other piece that is still quantitative is the diaphragmatic excursion, which is the up and down movement of the diaphragm. This will be the second part. Each one has its own way of assessing. As you can look at the picture, when we assess the thickness of the diaphragm, we'll go all the way to the lateral view of the chest. Versus when you do the excursion, because you are aiming to the dome of the diaphragm, you need to be in the subcostal. And different probes too. In the thickness, you need to use the linear probe, versus in the excursion, you have to change the probe to what we call the curvilinear probe. The second way is not quantitative, it will be qualitative assessment of the diaphragm, which by eye pooling, looking at the movement of the diaphragm just by your eyes without doing any measurement for the diaphragm. This is the first part, the qualitative assessment of the diaphragm by eye pooling. And if we run this video, you can, by only looking at, so as you know, from the previous presentations, this is the liver, this is the diaphragm, this echogenic part that separates the abdominal contents, liver, and here the kidney from the lung itself. And you can see some B lines, you can see them here. Looking at the diaphragm, you can say, yeah, there is good contraction or excursion of the diaphragm, this up and down movement of the diaphragm without even doing any measurement. Similar here, and I need you to focus between these two lines. This is how the diaphragm looks like in the area of opposition. So I'm using the liver as our acoustic window. And this is the upper white line is called the parietal or the pleural border of the diaphragm. And the one below is the peritoneal layer of the diaphragm. And this black in between, the hypoechoic area, is the muscle itself, the diaphragm itself. And if you look at these two lines, as the baby is breathing, you see these two lines are narrowing during expiration and getting thicker during inspiration. And this movement keep repeating itself. If you look at these two lines, see them narrowing, widening all the time. And if you do the M mode, you can see them in this widening, then narrowing, widening, then narrowing, as you see in this M mode. So this is what we call the eye pooling without doing any measurement for the diaphragm. The other way that you, if you are going to do this one for academic, like to publication, you have to do the quantitative assessment of the diaphragm. And as I mentioned earlier, you need to report the excursion and you need to report the thickness of the diaphragm. To do the excursion, again, you need to use the curvilinear probe. And I'm going to explain it more in the subsequent slides, but this is again another slide where I bring all together so you can understand both methods at the same time, and we'll talk about the details in the subsequent slide. So you position your probe in the subcostal, the curvilinear, looking upward toward the diaphragm, because now what's underneath you, below the skin, subcutaneous tissue, is actually the liver. And you are using the liver as a acoustic window for the waves to travel through the liver and reach to the diaphragm, where you can see the movement and assess the movement of the diaphragm. And this is where the probe is. So this area represented here, where the skin starts, and this is the liver, and this is the diaphragm that you're going to assess. And if there is normal diaphragmatic movement, there is no paralysis, there is no eventuation, what you expect is the diaphragm during inspiration will start to move toward the probe. When it moves toward the probe, similar to echo and other Dopplers, it gives you a positive deflection. So it goes up above the baseline. And this is how you see the excursion of the diaphragm. And depend on the rate of breathing, you will see like multiple inspiration, expiration cycle, then pause, then inspiration, expiration, and goes all the way. Okay, so this is the diaphragmatic excursion. For the diaphragmatic thickness, you change the probe to the linear probe. And because, as I mentioned earlier, you need to measure the thickness at the area of opposition. And remember, this is just below the thoracic wall. So you need a high frequency probe. So it will give you a good resolution of the superficial part of the lung, which will be the diaphragm. And in here, you will be seeing more or less the same, but you will see skin, subcutaneous tissue. Then the diaphragm will come as the two layers that, as I indicated earlier, the peritoneal and the pleural layers, and the muscle will be in between. And again, as I will show you in the subsequent slides, if this is the dynamic video, you will see narrowing, widening, narrowing, widening. And the narrowing represents the expiration, and the widening represent the inspiration. And you will be able to measure this to AA points, which is the narrowing part, represent the thickness during expiration. And you can measure the BB, the 2 points here that represent the thickness during inspiration. The diaphragm is as any muscle of the body. When it contracts, it becomes thicker. And when it relaxes, it becomes thinner. And we need to remember this fact. So let's talk about the thickness and come very close to how we do this one by ultrasound. So first, what probe you need to use? You have to use the linear probe. If you are assessing the thickness, then the probe has to be the linear, and linear can be the flat one or the hockey stick one. Any linear probe will be appropriate to assess the diaphragm. And where to position your probe? To be precise, you need to position the probe between the anterior axillary line and the mid-axillary line. And the area will be somewhere between the 7th rib and the 9th rib. And as a principle, similar to any type of point of care, if you are doing echo, if you are doing abdominal ultrasound, if you are doing vascular, if you are doing head ultrasound, when we say you need to be in this area, like the anterior axillary and mid axillary, and between the 7th rib and 9th rib, this is your initial position of the probe. But you might need to move it a little bit toward the anterior axillary, or you need to move it down toward the middle axillary, or a little bit up, or a little bit down until you get the perfect picture. So there is no magic dot that I will say if you put it on at this position at the 8th rib, it will give you the image immediately. No, you need to manipulate your probe, moving a little bit up or down, and from side to side, anterior axillary versus the mid axillary. But roughly, this is the area that you will find the best area to look at the diaphragm and measure the thickness. And to narrow this one, this is the whole chest one, and we are looking actually to this circle. You see this area down here in this cartoon? This is where you need to measure the thickness of the diaphragm in this area, and to focus more, your linear probe will be on the skin on this area here, and you will be looking at this thickness of the diaphragm. No lung should come in your view. What you will be target will be little part of the lung and the liver, and the first part of the diaphragm above the liver adjacent to the lung. This is called the area of opposition. I'll show you some image for this one. So here, what I'm referring to, so you are using, this is the end or the base of the lung when you are doing R2 or L2 on the other side, or R3 or L3, because you are more lateral. And it will show you the end of the lung in here. You can see the pleural line. You can see the rib, shadow of the rib. Then the liver comes in here. If you are in this area, the area of opposition, the next part will be the diaphragm that you will see on top of the liver on the right side, or the spleen on the left side. And you need to track this one by looking, but this will not help you by doing actual measurement. You need to use the M mode. So this is the 2D picture. Now I'm in the right spot. I can see the two border of the diaphragm. Then you put your M mode in the middle of this one, and you have to have these two lines. And this will be the result, the M mode, that you will see the parietal part will be fixed in here. And you start to see the diaphragm during expiration, the narrowing, and during inspiration, the widening. And this cycle will continue, depend on the rate of breathing of your baby. And you have to have, as you can see in here, at least 3 cycles, because we can't do the measurement in 1 cycle only. Like, don't get like 1 expiration, 1 inspiration and say, I got the measurement. Because as you know, the baby's breathing can vary from breath to breath. And you need to make sure that you have the average for the diaphragmatic thickness during expiration and inspiration. So what we do in academia, I measure like 3 expiration, sum them and divide them by 3 to get the expiration. Then I do the same, 3 inspiration, 1, 2, 3 minimum. Some people do 5 breath, 5 expiration, 5 inspiration, sum them and divide them by the number, 3 or 5, depend on number of cycles. And then you get the average thickness during inspiration. Any questions so far? Don't feel shy. And as I mentioned to Dr. Alok, I'm the person who does not like to give the whole presentation and wait for question, which is absolutely fine too. But if you have question with each part, we can explain it more. Unless it's clear, then we'll continue to move.
So Mayank, do you want to unmute yourself and ask, please?
Yeah, sure. So I was wondering if the thickness of the diaphragm would change in spontaneous during ventilator breaths if the baby is not does not have any breathing efforts.
I think this is excellent question, and I was coming to mention this one, that when you do the assessment of the diaphragm thickness or even excursion, the baby has to be on continuous breathing. So you cannot do it while the baby is on assisted ventilation, because this will represent the combination, what the baby is doing and what the ventilation is assisting with. It doesn't represent the independent function of the diaphragm by itself without assistance. So if you will do assessment while the baby on mechanical ventilation, you need to pause the mechanical ventilation. You might keep the baby on some sort of like CPAP to overcome the resistance of the tube if the baby is intubated, and you do the assessment while the baby on non-invasive or CPAP pressure, but not assisted ventilation. If you are worried that the baby is not functioning well, definitely you will not have exactly the same image as I'm showing you. And I'm going to share with you what if the baby is having paralysis secondary to chest surgery or PDA ligation or any surgery that can affect the phrenic nerve or recurrent or the phrenic nerve. Did I answer your question?
Yeah. Thank you so much. That was very clear.
Thank you.
Does anybody else?
Question? If no question, then we'll move. But remember, at any time, you can say, oh, now I remember question regarding the thickness, and we can go back and review this one more time. I believe that this is new for most of us, including myself. We just started to do the diaphragm and use it more or less regularly in the unit, I would say, for the last 2 to 3 years. So it's not something, even it came after learning the lung ultrasound. So I'm expecting that's new for most of us. Okay. Again, and I kind of described this one in the previous slide, which is you have to have the 2D. And once you are happy with your area of opposition, you can see the 2 layers. You see the contraction, relaxation, contraction. The relaxation is the narrowing, contraction is the widening. You are happy with it. Then you press on the M mode on your machine. Bring the line in the middle of your diaphragm. Don't bring it close to the rib because it will appear as black and represent the liver and the rib. And try to be in the middle because you can't adjust. The baby will not listen to you. This is not adult. Baby can move. So try to be in the middle. So the baby move, your M mode is still within the area where you can assess the diaphragm. So and this is my tip from my experience when we do the diaphragm assessment. So line the M mode in the middle, and this is how it will be reflected. You will see very nice narrowing and widening, narrowing, widening, expiration and inspiration. And as I mentioned earlier, you measure from inside to inside. Sometimes it's very difficult, especially in our babies, because the line is very thin. So either inside, or at least to be on the top of the line itself. What I'm referring to, this echogenic line and this echogenic line, because in our babies, not the same as adults. The thickness could be 2 millimeter or 1.5 millimeter, which was tiny movement of your cursor. When you do the measurement, you can change the whole equation and the measurement. Want to say something that I forgot to mention. As you can see here, because I know and I'm very sure Dr. Alok already discussed with you the depth, how deep your image should be. When it comes to the thickness, I need you to be as small depth as possible. You can see here is only 2 centimeter, and in some babies, the tiny ones, I use 1 centimeter depth, only 1. So all my focus will be, because what I'm looking for is actually between these two lines. That's it. I don't want to see anything below. Yes, part of the liver will come even if you do 1 centimeter, but this is what you are looking for. Then it will give you a more clear and wide image that you can easily measure. The more the depth, it will be narrow, and it will be difficult for you to measure, especially the expiration where it becomes very, very narrow and you can put your 2 dots. Make sense? So the focus will be against the diaphragm, so around 0.5 to 1. This will be the focus for your ultrasound machine. And the depth shouldn't exceed 2 centimeters. Even 1.5 centimeter should be fine. Okay. Any question for how you adjust what probe to use, where to position the probe, what to look for? And remember, I'm talking about zone of opposition, because you can see the diaphragm continuing here. This is still the diaphragm, the 2 layers. You can see it's still down here. If I move my probe more down, I can see the diaphragm continue in this area. You can't use it here. This is not the area of opposition. Area of opposition is the part of the diaphragm that's very close to the lung. If we don't have the shadow of the rib in here, because this black area is the shadow of this rib. If we don't have the shadow, you should see the lung coming just beside this area. And this is where you measure the diaphragm thickness, and not in any area be on the liver. Any question? Okay. So what about this diaphragmatic thickness fraction? You will hear about this one. Or some like to call it diaphragmatic shortening fraction. Actually, this is represents the efficiency of the diaphragm. So the diaphragm between inspiration, which is getting thicker, and expiration, which is getting thinner, should have at least 30% difference between the two. The more efficient the diaphragm, the contraction of the diaphragm. Okay, so at least 30%. And we use this one in babies to predict if the baby will succeed extubation or not. If the diaphragm is doing less fraction shortening, less than by 30%, you will be worried that this baby might not succeed the extubation. How we calculate the shortening fraction or thickness fraction? Here is the equation in blue. So you measure the thickness at the end of inspiration minus the thickness at the end of expiration. Then you divide all by the thickness at the end of expiration, and you time this one with 100. And this should give you a percentage of shortening fraction. And we found that a shortening fraction gets affected if the baby is on mechanical ventilation for a long time. And when we say long time, don't expect days. For sure days will affect, but even hours can affect the shortening fraction. That's why we use this one to assess, did the mechanical ventilation affected my diaphragm? Should I give the baby more room to breathe independent and less assisted by the ventilation before I try the extubation or not? Okay. There is a very famous term in adults called the ventilation-induced diaphragmatic dysfunction. And this is what I was describing now. When the baby on mechanical ventilation, and they mention up to like 6 to 16 hours on mechanical ventilation, expect that there will be some negative effect on the diaphragm. And the other important indication for assessing diaphragmatic thickness fraction is when you are assessing the lung aeration. And we found there is a linear relationship between the loss of lung aeration and the diaphragmatic thickness fraction. The more loss, the more harder the diaphragm will be working, as you would expect. Baby with parenchymal lung disease means less aeration of the lung. this baby will have a higher diaphragmatic thickness fraction. And we did a study on this regard that I'm going to share with you later when we do the literature review, where I will show you that the thickness fraction becomes bigger if the lung parenchyma is sick. Okay. Any question? Because I'm almost done with the diaphragmatic thickness measurement, probe, position, how to measure it, where to measure it, what depth, what's the diaphragmatic shortening fraction or thickness fraction, what's the equation, how to measure it, and where to apply it. I see a few hands. Please go ahead.
Yeah, I have a question. So I wanted to know is if the zone of apposition change with respiration. For example, does it move up and down with respiration? Because sometimes, for example, when we do IVC measurements, respiration actually makes it difficult because the same segment moves up and down during the respiration. So does it happen with the zone of apposition as well?
This excellent question. So I will reassure you, if your probe in the right spot, you are lucky. It will not move unless the whole baby move below you. Like if the baby changes the position up and down or side to side, and you have little bit slide of your probe from where the area that you were seeing the zone of opposition. Otherwise, you'll be able to see it if your probe in the same spot, baby is not moving. No, you will be able to see it clear, and it will not change position.
Okay, thank you.
Welcome.
Hi, I wanted to know if for this diaphragm thickness fraction, does it remain same for preterm and term, or is there any difference?
You are a few slides ahead of me, Kirti, so do you mind to wait until I share with you this one?
Yeah, thank you.
This work is actually done, and I will share with you the difference between diaphragmatic thickness and thickness fraction in preterm versus term babies.
Okay, yeah. Thank you.
Pleasure. Any other question? I'm not seeing all of you, so please either jump in or if we have Dr. Alok, then please indicate if there is any, because I see Rana, your hand is up.
Yeah, just two questions. If you've got the diaphragmatic thickness, like in absolute terms, are there any normal values for depending on gestation and weight? I don't know if that is the case. And the other thing,
you guys ahead of the presentation, okay? Excellent. The short answer, Rana, is yes.
Oh yeah, thank you.
Yeah.
And the other thing is with the formula with the diaphragmatic thickness fraction, because when if it is the same as the fractional shortening of the systolic function of the left ventricle, is you divide it by the bigger number, which is end inspiration should be in that formula.
It came to my mind the first time I used this one, but this is the definition and the formula that is used by everyone. Is actually using the denominator will be the end of inspiration and not end of inspiration. But thank you for the question.
Yeah, thank you.
Pleasure. Any other question? Okay. Again, this is not one-way presentation. If you remember anything, we can go back and review. So this to answer not the last question, the one before, if there is any difference regarding the thickness for term babies versus preterm babies. And the short answer, as you can see, so this work was done very early, almost 20 years ago. And what they found, they started by 37, which is the definition of full term, all the way to 41 weeks. And as you can see, the dimension, which reflect the thickness of the diaphragm thickness fraction, get a little bit smaller, but not significant difference. So once you have the full term, it becomes more or less the same for full term babies. And I have another paper published by one of the instructors for this course, Dr. Alonso, who actually give us some reference number for full term and preterm babies. But this is just to give you a glance that for full term babies, it's more or less the same. Comparing to the preterm babies, and this study did it from 24 weeks all the way to 38. And as you can see, the diaphragmatic thickness and thickness fraction become bigger and bigger, as you would expect. The diaphragm muscle is like any other muscle of the body, is growing as the baby grows, and actually has direct correlation with body weight. So if you bring two babies, 30 weeks, both of them, one is, let's say, 2.5 kilos and one is 1.5 kilos. The bigger baby expected to have a bigger size of the diaphragm dimensions and consequently will be thickness fraction. Compared to the small size babies, their diaphragm will be also small. But with progression in gestational age, expect that this will be constantly in a linear relationship, positive linear relationship with gestational age. And I can add with also birth weight. Okay, I hope this addressed the question for our colleague who asked about if there is difference between preterm and term babies when it comes to the diaphragm dimensions, thickness and thickness fraction. Okay, we'll move to the second part of ultrasound assessment of the diaphragm, which is diaphragmatic excursion, which assess the actual movement of the dome of the diaphragm up and down during inspiration and expiration. Again, we'll do the same systematic way. We'll look at what probe to use, where to position your probe. Also, we can talk about the depth of the ultrasound. So to assess the excursion, you have to change your probe from the linear probe to be the convex or curvilinear probe. Okay, this is one. The second, you need to be more subcostal. And where exactly will be somewhere between the mid-clavicular line and the anterior axillary line. And your probe will not be looking similar to the lung ultrasound, like perpendicular with your marker looking at the head. You need to tilt it a little bit to the right side of the patient. So kind of looking up and posterior and to the right side, as you can see it in this position of the probe in here. Again, when we say this one, this is just a landmark for you. But if you put it in this way, and the baby is actually a little bit tilted to the left or leaning more to the right side, it might not give you the perfect image where you can do the assessment for the excursion. Then you need to adjust your probe in a way to get the right image. In regard to the depth, how deep should be when I do the assessment of the excursion, in my babies in the unit is usually around 6 centimeter depth. See the huge difference in excursion with 1.5 maximum 2 in the thickness. When it comes to the excursion, because you go and use the lever as your acoustic window, then you need this low frequency probe, which is the curvilinear. You need to cross all the way through the lever and looking up to see the dome of the diaphragm and track the piston action of the diaphragm. That's why you need this, like at least 6 centimeter depth. If you see that the diaphragm is not clear for you, then you can increase the depth more to bring the diaphragm into the frame, but not make it like too deep. Then you can't get like a good resolution for the diaphragm itself. And this is one of the reasons why you are using the convex or the curvilinear, because this is a low frequency one, so it can travel to a deeper structure. What you will expect to see, your probe, remember, is here at the top here. is coming through the liver, looking at the diaphragm. When the baby inspirates, which means the diaphragm moves toward the abdomen, means the diaphragm moving toward your probe, it will give you this deflation, the positive one. Okay? And when the diaphragm starts to move back during exhalation, then it starts to fall down. And this is the inspiration arm, and this is the expiration arm of one breath. Okay? And I'm going to discuss in the subsequent images how we can measure the actual excursion in millimeter and report this one if you need to report it as a number. But I will stop here if you have any question in the technique, the position of the probe, and the depth of your image.
Sorry, but just one question. Can we use another probe than curvilinear or convex, for example, the probe of cardiac ultrasound if we don't have it?
I would say you can try the phase array, but the ideal one would be the curvilinear. I never tried the linear, if you are referring to linear too. Because the resolution will not be good. If you use the linear, definitely the phase array can help. And the ideal one, as I mentioned, is the curvilinear.
Adel, I have a question. So just in terms of the frequency that you use, I mean, any particular frequency that is better in terms of a minimum that you would have?
Yeah, for this one, what we have is 5 to 8 will be a good like low frequency probe.
Thank you.
Yeah. Any other question?
Naz, you have a question?
I think you asked my question, Alok. But can I also ask Adel? So the probe, essentially, you're putting it vertical and then you're tilting it towards the right side. So the marker on the probe is actually facing the right side towards the axillary side?
Not facing right completely, as you can see it like tilted toward the right side.
Okay.
So it's not a transverse one.
Okay.
And Naz, I need to stress this one. I like when we discuss this one that you have this flexibility when you use the probe, and you are not. I need to remember exactly what Adel said. He needed kind of looking at, I will say 11 o'clock or 10 o'clock around this one. No, be flexible. Start with this one. The whole idea that I need you to focus on, not your hand. Remember, when you do driving, you don't look at your steering wheel. You hold the steering wheel, but you look up front to see your road. Similar, when you do the scan for any of the above, you put the probe in the expected area that will give you the best image, but your eyes should be on the monitor of the ultrasound. And start to play with the position and orientation of the probe to get the image that will help you to do the proper assessment. I show you the how the area of opposition should look like, and you need to remember it has to be this way, no other way. You can measure it unless you get it this way. When we come here to the excursion, you need to bring the diaphragm as much as you can below the level. Most of the time, it will be kind of coming tilting, and I hope you are looking at my hand. So the lever is here and the diaphragm. Ideally, it should be this way. If you can see my hand, this is the diaphragm. And your M mode would be perpendicular on the diaphragm. This is ideal. In most of the cases, this will be difficult, and it will be tilted this way. And the lever is here. Then you bring your M mode kind of perpendicular, up to 20-degree difference from the 90-degree, still acceptable, because I don't want you to get the diaphragm this way. See, like almost parallel, and you put your M mode tangential, like 30-degree, and you say, I got the diaphragmatic excursion. No, this is misleading. And the number you will get will not reflect the actual excursion for the baby. Has to be as much as you can below the liver. Your M mode has to be perpendicular and not tangential to the diaphragm to get the right measurement, which is more or less similar to what you are seeing here. So you just start from what we recommend, which is between the mid-clavicular, anterior axillary, subcostal. Start by looking up and to the right. But if you feel that this is not the image that you are getting, please start to rotate your probe a little bit to the right or to the left to get the image in the right orientation. So what you will get as excursion will be actually reflecting the baby's excursion and not because of operator orientation. Does this make sense for you guys?
Yes, thank you.
Pleasure.
Doris, you have a question?
I was just going to ask about the frequency again. Is it the same frequency we use for term and preterm babies? You said between 5 to 8. So is it the same or we change it?
No, I use the same, exactly the same for preterm and term babies. I have one machine. I'm expecting a second one. And this is not to talk about the echo one. We have another 2 for echo. And I'm getting a second one for our unit for this one. But when I did a study that I'm going to share with you for preterm and term babies to compare their diaphragmatic function, I used exactly the same probe for both of them and worked fine. You might need to play, Dorsey, you might need to play with the depth a little bit, increase the depth more when you are dealing with full-term babies or big-size babies in general. Compared to the small one, you might not need all this depth.
Sujit?
Yeah, Adele, can you just talk us through the M mode, the peaks? Do they represent inspiration?
Yeah. So let me see what's the next slide might give you. Yeah, here. So this is a baby from the unit. And as you can see, like lots of B lines because this lung is their premature lung. This is the probe is somewhere in here. And this is the liver. I'm going through the liver. My M mode more or less perpendicular on the diaphragm. Run it one more time. As you can see, the diaphragm is contracting and is giving me this excursion. How we do the measurements? So we go from the maximum peak of this positive deflation of the wave, and you draw a perpendicular line to the baseline that touch the base for at least 2 to 3. And before I forget, exactly the same as we did with the thickness excursion, you measure at least 3 or more, and you get the average. Because baby can fluctuate from breath to breath, and you need to make sure that you get the average excursion for this baby. So to do the, and there is multiple ways as I'm going to discuss, but the classic way of measuring the excursion is to go to the peak of this wave, which end of inspiration, and draw a perpendicular line to the base, and this will be the excursion for this baby. If your question, Sujit, where you define the inspiration and expiration, same. From the baseline, this is the beginning of the baby taking inspiration, goes all the way to the peak. This is the end of inspiration. And when the baby starts to exhale, you will see the down slope of this wave until it reaches to the base where a second cycle of inspiration, expiration starts.
Perfect, thank you.
And I'm going to explain different ways of assessing the contractility of the diaphragm. But the classic one that I need you to digest it very well, most of the time reported this way, is a diaphragmatic excursion, and the way of measurement is the way I'm showing you in here. Any question with this one? How to position, what probe, where to position the probe, the depth, what you are looking for, and how you measure excursion in millimeters. Okay. There is another way of assessing the diaphragmatic contractility or movement. So one of them, and this is all reported actually in literature, is called inspiratory velocity, which means what the speed of the diaphragm. If the diaphragm is like dumb, like my hand now, how much time the diaphragm needs to move from this shape to the abdomen down in inspiration. So this will be the distance divided by seconds. So the speed of the diaphragm to reach to its peak from this white dot to this white dot, if you measure this slope this way, not the perpendicular line. Remember the previous one, you measure from the peak to the baseline. This is what the definition of the diaphragmatic excursion. But the diaphragmatic or inspiratory velocity, you measure this distance divided by second, and most of the machine can do this one, especially if you are using the echo machine. It can actually measure for you and give you a number. Is it like 1 millimeter per second, or how long it takes? So this is the inspiratory velocity. In case you become interested more to read more about diaphragmatic function, so if you see the expression in inspiratory velocity, this is what it means. What is the speed of the diaphragm going from end of expiration to the peak or end of inspiration? The second one, what's the inspiratory time? Like it takes how long from the beginning of inspiration to the end of inspiration? And this will be the distance between the two red lines, beginning of inspiration to the end of inspiration, and this will give you the inspiratory time. And similarly, the expiratory time will be the distance between beginning of expiration to the end of expiration between the red and yellow line. This is more for academia. I didn't use it myself or see it used in literature, except the inspiratory velocity. Some people now start to report the inspiratory velocity instead of the diaphragmatic excursion, or both together. They will report the diaphragmatic excursion and the inspiratory velocity. Any question for this terminology and what it means and how to measure it?
Sorry, is this not related to the respiratory effort and the respiratory rate of the baby? The
Correct.
velocity.
So yes and no. Yes, because each cycle, each inspiration, expiration represent a breath, complete in and out. And this will be how many breaths. And if you have this one, like for example, if you say that this is 1 second, I will say that 1, 2, 3, 4, 5, this baby is breathing 5 breaths per second, for example. But what we are referring to by inspiratory velocity, inspiratory time, expiratory time has nothing to do with the rate itself. This is in each within a cycle of in and out. What will be the velocity? What will be the inspiratory time? What will be the expiratory time within one cycle, for example? And you can do multiple cycles and average them too. I hope I didn't take you a little bit far, because I still, my interest, if you come out of this presentation with two things: how to perform diaphragmatic thickness and measure thickness in inspiration, expiration, then do the shortening fraction or thickness fraction. This is one piece. And second piece, how you can assess the diaphragmatic excursion, which the previous slide, this one, how to measure the excursion. This too is actually, you can use them in your practice, not for academia, not for only research. We are using this one for research too, but you can use this one, the thickness and thickness fraction and the excursion, to assess the baby before extubation, for example, which is my interest to pass to you today, is the clinical piece, because I believe all of us, first job is clinician, and how we can learn something to help you make an informed decision at the bedside. This is the aim, the primary aim of the presentation. But I gave a little bit extra in case you will be more interested and you start to read stuff, then you know what each terminology of this one means. Any question? Okay. I'll consider
One small
again. I'm not seeing all of you. Muhammad,
yes, just so did this measurement of diaphragm, all these indices, help in, for example, scoring the severity of respiratory distress or pneumonia or any lung disease?
The short answer is not. No one make this correlation, except if you are talking that pneumonia affected the lung aeration, which it will do, then definitely you are expecting that the phragmatic thickness fraction will increase, because this baby will be working hard to breathe, and which mean more contraction, and you'll have a bigger inspiratory thickness, and compared to the baseline, the expiratory one, and this will lead to a higher diaphragmatic thickness fraction. But it will not do the other way around. You have your direct tool, Muhammad, as you learned from the previous presentation, that you can look at the lung parenchyma using the lung ultrasound. You can assess the presence or absence of pathology like pneumonia, and you can even do the measurement for the pneumonia and see how big or how small, and you can start your management and follow up your baby. So I will not use the diaphragm to help me assess what's going on with the parenchyma. I'll go and ask the parenchyma direct.
Okay, thank you very much.
Pleasure. Any other question? I'm sorry, I'm not seeing all of you again. So feel free, please, to jump in and mute yourself and talk. Okay. What about diaphragmatic paralysis? And this is not an uncommon question, I will say. I've been asked this question a couple of times. We are tertiary unit. We receive lots of complicated cases that comes to the unit. And some of them, babies will have congenital anomalies. And the baby's full-term baby still dependent on the respiratory support. And the question always comes, does this baby have a good diaphragm? So you can assess what we already discussed before. And you can have some reference from the paper that I'm going to share with you to see if this baby have a reasonable function for the diaphragm or not. But also, if your hospital or your unit receive babies post-surgery, especially thoracic surgery for any reason, there is the risk that the baby might have diaphragmatic paralysis. And you will be surprised that it's very, very simple. If you learn how to do the expulsion, definitely you'll be able to say if the baby have a diaphragmatic paralysis or not. So we discussed this slide before. So you bring the lever, your probe is actually here. This is the lever, and this is the diaphragm. And if you are using the M mode, then this is the normal, because when the baby starts to breathe in, which means inspiration, the diaphragm will move toward the probe. And then you will have positive deflation above the baseline. And this is what happened here, and we discussed it a few times. And when you start to go back in expiration, you start to see it going toward the baseline. And this is repeated all the way. This will not happen if the diaphragm, like for example in this baby, is actually paralyzed. The baby will have what we call paradoxical movement, the reverse. So during inspiration, because of the negative pressure in the chest, the diaphragm will go up, so away from your probe. So it will be drawn for you as a negative, below the baseline. So you see like flat, With one inspiration, it goes down. So if you have this one, reverse it. This will be your hint that there is diaphragmatic paralysis in this baby. I forgot to mention that, and you see most of the examples that I shared with you, I'm using the level, because always the assessment of the right side is much easier than assessment of the left side, giving the small size of the spleen. Little bit challenge, but not impossible. You can definitely do the assessment of the left side, but the easier side always the right side because of the level. Give you a big acoustic window where you can see the diaphragm. Any question how the diaphragm, paralyzed diaphragm will look like?
Yeah, I have a confusion. So most of the times these babies would be intubated. So post-surgery or if there's significant distress, they would be intubated and under mechanical ventilation. So there would be movement of the diaphragm anyways due to positive pressure ventilation. So how do you differentiate?
So, Manak, this is excellent question. Again, even if this baby is ventilated, you have to pose so you can adjust everything. You bring your machine, you put the probe, completely hearing you. So this is my probe. My baby is on mechanical ventilation assisted one. What I do practically is I bring my machine, everything is ready. I put the probe on the proper position. I can see the diaphragm, I see the lever, I see everything. Then I ask either the RT or the bedside nurse or yourself, you pause the machine for 10 seconds, 5 seconds, according to the tolerance of your baby. But you need to put the baby on no support except some kind of CPAP to maintain the FRC. And then you assess the spontaneous movement of this diaphragm. You can't assess the diaphragm while the baby is on mechanical ventilation. No way.
Okay. Thank you.
My pleasure. And most of these babies will tolerate because you pause for only this few seconds. And if you need to repeat, you give the baby a couple of breaths, then you pause again and you repeat your scan one more time. Any other question? Okay. I think this is the two parts that I need to discuss with you. Now I'm going to some literature review. Again, to share with you some evidence of the utilizing of the bedside ultrasound to assess the diaphragm and end up with some conclusion. But feel free if we need to go back and review some of the technique of assessing the diaphragm. And I like to start with this one. And as I mentioned earlier, Dr. Alonso is one of the instructors. I'm not sure if she gave you presentation or not, but if she didn't, she will present for you. She's one of the excellent physician in the field of point of care, especially lung and diaphragm ultrasound. And she put this title for editorial in the chest, I believe in 2022. And this was a comment on a paper that our group from Toronto published. And she used this title that I like to start with this one. Can diaphragmatic ultrasound become a new application for point of care ultrasound in preterm infants? And in her comment, it's only one page, and I believe it's open access. You can Google it and you will get it. It's kind of yes. The short answer was yes, but it was nice commentary on our paper. And this is the paper that we did in our unit and published in the chest. Diaphragmatic thickness and excursion in preterm infants with BVT compared to term and near-term babies. I used the healthy late preterm babies and term babies as my control because this was the first ever study that looked at babies with BVD and how their function from the diaphragm thickness and excursion. And just not to go through all the details, need to share with you these two parts. As you can see, diaphragmatic thickness fraction is almost 60%. compared to around 40% for the healthy group. 40 is around what you would expect. Remember, we mentioned 30 is the minimum. Below 30, you know that there is a dysfunction of the diaphragm. But our babies with BBD and chronic lung changes, and this is the baby who were still on oxygen or respiratory support at 36 weeks, because this is how we define BBD. Definitely, their babies was working harder to breathe. That's why they have a bigger diaphragmatic thickness fraction. And similarly, when we assessed the diaphragmatic excursion in millimeters, it was higher, which represent the contractility of the diaphragm up and down. So it was around 6. This is the mean standard deviation compared to 4.4 in healthy babies, which kind of expected, but it was never studied before. And this was the first time to show how we can assess the diaphragmatic thickness and excursion in preterm babies with BBD, not healthy preterm babies. Again, Dr. Alonso, you see here, was asked in this presentation, and this was one of our colleague in the group asked if there is reference number for preterm babies and term babies and how it looks like, and is it correlated to the gestational age and size of the baby or not. And Dr. Alonso and her group again give us the reference value for the diaphragmatic shortening fraction in term babies and in preterm babies. And as you can see in all measures, left side and right side of the diaphragm, in both it will be bigger and higher in the term babies compared to the preterm babies. Okay. I brought this one just to share with you that this was a paper published looking for what could be the application for ultrasound to assess the diaphragmatic function. Again, we discussed it can be post-surgery to assess the diaphragm, but the most common used one in our population, especially all of us and neonates, will be to assess the diaphragm for babies who are on mechanical ventilation, to assess can you wean the pressure, and also can you extubate the baby. So this is the most common one. Again, if a baby with neuromuscular disease, it would be nice to know if the diaphragmatic function is preserved or is very low. You can see the excursion is very low if you compare it with the reference numbers. Similarly, if there is skeletal disease, there is receiving medication, muscle relaxant, any of this indication. What's the definition for long-term mechanical ventilation? Does not mean weeks or months. This paper is talking about 6 hours per day for 3 weeks. And there is another paper in adults. For adult population, they consider 16 hours. Mechanical ventilation is enough to cause some diaphragmatic dysfunction for someone who's in mechanical ventilation. It's scary how it looks like. I'm hoping at some point that we will do similar in neonates, because there is no one in neonates that follows the babies day by day to see how the diaphragmatic thickness and thickness fraction evolve over time as the baby grows, especially for babies who stayed on mechanical ventilation for some time. Again, what's the effect of mechanical ventilation on the diaphragmatic muscle? It causes thinning, make the muscle, because you can remember this one if you have ever been in a cast because of bone fracture. Any muscle that does not get used fully become atrophied and become thinner. And this was happen. You can see from day one ventilation, this is where the diaphragmatic thickness was. And as this patient was on mechanical ventilation for up to 8 days, you see the thickness become less and less and less. And this is adult population, by the way. Similar work was done in children, exactly the same work. And they went to 7 days of ventilation, and they measured the thickness from day one to day 7. And again, they showed that there is progressive decrease in the diaphragmatic thickness that correlate with the duration of mechanical ventilation. Scary, right? But it explains part of this one, explain also why some babies fail to come off despite they were on minimal respiratory support, right? We don't extubate babies who are on very high pressure. Extubate babies on or reasonable pressure, almost room air of 25%, everything looks fine. And despite this one, some of them, when you take the tube out, baby will fail and need the tube back. And you wonder, what's going on? The lung looks fine, the setting was not high, why the baby is failing? You need to think of the diaphragm as another layer or another reason that could put this baby in failure. And you need to prepare the baby by decreasing the support and allow more diaphragm function before you take the tube out. There was a question from, I believe, Dr. Muhammad, or one of the group, asking pneumonia and or parenchymal, I would call it parenchymal lung disease, and diaphragm function. And again, you will see that there is correlation between lung aeration or lung pathology and the diaphragmatic function. It become, and here they divided the population into 2 groups. If the score less than 14, and if the score is more than 14, significant lung pathology. And as you can see, there is significant difference between the 2 groups, mean the group with thicker lung will be working harder, and their diaphragm will be giving more thickness and thickness fraction. You might ask here and say, okay, now I'm confused. You say, if the baby needed support, the diaphragm will be thinner. This is if you are using assisted ventilation. But if you are on non-invasive ventilation and the baby has his own control and there is lung pathology, you actually overworking the diaphragm. And as any muscle, when you use the muscle a lot, it becomes thicker and the thickening fraction will be higher in this phase. Another paper study that was conducted in Egypt and looking for assessing the diaphragmatic thickness and expulsion as a predictor for successful extubation in mechanical ventilation. This group used or enrolled babies who are born at less than 32 weeks, who were on mechanical ventilation, and they did the ultrasound 1 hour before planned extubation, and they defined a successful extubation as a baby stayed off invasive mechanical ventilation for at least 3 days, and they measure the diaphragmatic thickness and the thickness fraction and compare this measure between the 2 groups. And their conclusion was that especially the excursion was a useful indicator of successful extubation. So higher excursion
Adel, we can't hear you. Sorry.
You can't hear me?
Yeah, now we can hear you. Yeah.
Okay, I'm sorry. I don't know.
No, that's all right.
Is it from the same slide here or?
That's correct. Yeah.
Should I start from the beginning, or you guys heard what the study was about?
You can start again, no problems.
Sure. So I was saying that this study was done in neonates, looking for or utilizing the diaphragmatic assessment, thickness, and excursion to define which babies will be more successful when you try extubation. Inclusion criteria was babies born less than 32 weeks on invasive mechanical ventilation, and the ultrasound was done only an hour before the extubation, and they define successful extubation as baby stayed off mechanical ventilation for at least 72 hours, And they did the thickness fraction and excursion, and they compared it between the two groups. As you know, you do the scan, you go ahead with the extubation, you stay for 3 days, then you see which group failed, which group success. Then you go back to the ultrasound and see what the criteria for the ultrasound for the failed group versus the successful group. And they found that diaphragmatic excursion, a good diaphragmatic excursion, was good indicator for successful extubation. We did similar work, but we used actually very, very, very small babies, because in our unit, babies who are 26 weeks and above, most of them will not be intubated. They are fine on non-invasive ventilation. So I had to repeat more or less the same study, but on the extreme preterm babies. You see the mean gestational age for the successful group was 25 weeks, and the mean gestational age for the failure group was only 24 weeks at the time of the scan. And we did not only the assessment of the diaphragm, so we did the diaphragmatic thickening and thickness fraction, and we did the excursion, as you can see, and we did the measurements from the babies, but we added also how the lung looks like. So we did the lung ultrasound score, which is a little bit different from the score that's commonly used in most of the literature. So we did like 5 patterns from 0 to 4, but we can talk about this one in different setting. And what we found in our paper that because these babies have a very, very thick lung, the big difference was actually in the lung ultrasound score. And we couldn't appreciate a big difference when it comes to the diaphragmatic excursion. Both of them, success and failure group, was working hard to the point that their excursion were more or less the same, 3.4 versus 3.5 millimeter. Is it the sample size? Because this was only 36.9 babies. Is it our measurement? Remember what I was saying to you, make the depth very small, so you have a good view and you can do proper measurement. Could be any of the above. Definitely the study need to be repeated on a larger sample size. But again, another tool that we used it to assess the readiness for extubation in extreme preterm babies. This interesting paper that I actually not published yet. This paper is not published. It was sent to me for review, and it got accepted. So that's why I have the permission to share, because accepted, it's coming hopefully soon in the frontier. So this group did something very interesting. They were looking for the relationship between the PDA, especially the hemodynamic PDA, and the inspiratory velocity. Do you remember the diaphragmatic inspiratory velocity? Anyone remember what this one was about? I'm testing you.
Yes. If you
Yes,
want, this is the time to reach maximum inspiratory peak of diaphragmatic contraction.
Excellent. As it shows here, the T(I) or T1 is how long it takes from the diaphragm, from the beginning of contraction or inspiration to the maximum in here. This is the regular excursion, the D. Okay. And they found very interesting finding that in babies with hemodynamic significant PDA, there was association with lower, like lower diaphragmatic velocity. And they concluded that there is possible association between the hemodynamic significant PDA and the negative effect on the diaphragmatic function. Again, I was having some concern in my report, but this is only all in all 17 babies or 18 babies. And it was the retrospective study. It's not a prospective and very small sample size, but it gives us another perspective. Should we study the diaphragmatic function in babies with hemodynamic significant PDA? You know, the heart and lung are kind of one organ. They talk to each other a lot. And we need to think of all the factors that can affect the diaphragmatic function, especially for babies, as I mentioned, who are on invasive mechanical ventilation. I'd like to share this one with you. Last but not least, again, this study was done to diagnose if there is abnormal diaphragmatic motion in infant after heart surgery. Again, they are looking for diaphragmatic paralysis. We discussed this one before. Again, in normal, you will see that the inspiration is in the positive side, so above the baseline. But if there is diaphragmatic paralysis, this is your baseline here. You see the inspiration are all paradoxical movement. It's coming down in the negative side of your baseline. Okay, I think this could be the one before my last. So in conclusion, then we'll open the floor for more questions if you have more questions. That diaphragm ultrasound is a new point of care ultrasound application that we start to use it more and more in the NICU. And diaphragm ultrasound could help in assessing extubation readiness and weaning from non-invasive ventilation and invasive for sure. And diaphragmatic dysfunction is a major contribution to the prolongation of mechanical ventilation. So we should consider it and try to extubate the babies as soon as they are ready, even if you will use non-invasive, higher pressure or non-invasive ventilation. And diaphragm ultrasound is one tool. The last one is one of your tools and not the only tools. So as we discussed before, you have to do the lung ultrasound first to assess how the parenchyma looks like. You have to look at how much pressure you are using, how much oxygen that the baby is using, and how the diaphragm function, and you put all together to make your clinical decision. So don't take one of this one, like lung ultrasound, then you treat the baby based on the lung ultrasound alone, or diaphragm ultrasound, and use the diaphragm ultrasound to make the decision without looking for the other part of the patient's clinical status. So always consider any test, blood gas, the setting, the CO2, the diaphragm assessment, the lung parenchymal assessment. You put all together to make your informed decision regarding your baby. And I think with this one, I reached to the conclusion. Thank you so much for your attention and happy to take questions.
Dr. Adil, can I ask you a question, please?
Sure, yeah.
Yeah. So Dr. Adil, maybe you did explain this. So if the baby in assisted ventilation, how are you gonna see the wave when you put the M mode? How are you gonna see the M mode if the baby in assisted ventilation? Maybe you explained.
Yeah, I think this is a very important question because it came a few times. And just remember, we don't assess the diaphragmatic excursion while the baby is fully supported with assisted ventilation. You need to pause the or stop the assisted ventilation, put the baby on some kind of CPAP, what we call same when you do the SBT, spontaneous breathing test. You don't use it, you do spontaneous breathing test while the baby is on full assisted support. So you need to pause this one to the time for the time of the scan.
But have you ever put them in mode while the baby in assisted ventilation? Have you seen the wave? I mean, out of interest.
It will not reflect the baby's own movement, but no. The short answer is no.
Okay. Can I ask another question?
Yeah, please.
You know, during paralysis, how do you know this wave is because the baby breathes very fast? How do you know this wave is actually, you know, opposite to the normal, or is it just a damped wave?
So you look at the fold trace. If this is one, but all the others on the other direction, you question your technique. But if all consistently in this side is coming to the reverse, and you do the other side, hopefully this is not a complete paralysis on both sides. So if this is differential, you have the right side paralysis, left side is not. Then in the same patient, you can do both, and you'll see the difference between the two. We knew from even before with the fluoroscopy and other types of assessing of the diaphragm, that with diaphragm paralysis, you will have what we call the paradoxical movement, the reverse of the node.
Okay, thank you.
It's my pleasure.
Anna, you have a question?
Yes, maybe I didn't listen, but I don't know if you referred the normal values of the diaphragmatic excursion in term and preterm babies.
Yeah, there is one paper published in this regard. I didn't share it here. What I shared was the thickness. And what Dr. Alonso published was regarding the thickness on the right and left side and term and preterm babies, which I can share both with Dr. Aloko, who can share it with the group.
I'm really grateful. Thank you so much.
I
Any
have
other
a quick
questions?
query. Yeah, I have a quick query. Question. Am I audible?
Yes, we can hear you.
Okay. So I was just wondering if we can use qualitative assessment for diaphragmatic palsy, and can we actually put the probe in the subxiphoid region and basically can visualize both the domes of diaphragm together. Would that be possible, or has it been tried?
I believe it was tried. I read this one time. Depend on the footprint of your probe. And also to make sure that not most of your image is actually visualizing the heart. Because with this position, the heart comes right in front of you. But if you are able to put the probe in the subcostal, either below the xiphoid or a little bit toward the right side, directing the probe a little bit to the left side to capture both, is an idea. Not sure about the reliability of this one because all the studies that looked at reproducibility and reliability of the test did it independent. You assess the right side and you choose the right spot and you do the left side independent and not to combine both. But have we done both in the same time? Yes. I read it one time, but can't remember which.
Okay, thank you.
I have a question, Adele. So one of the challenges that we sometimes face is you occasionally get babies with right-sided diaphragmatic hernias where the diaphragm is high, and or you have babies who might have eventration with the liver. I mean, have we looked at whether we can differentiate these two conditions using ultrasound in particular by trying to demonstrate diaphragmatic movements?
So I will divide your question into two. Look, just to make sure I understand it well, and start with the eventration. So eventration is kind of weakness of the diaphragm. So it's not zero excursion. So you will see some tiny movement, but not optimal to call it as a normal excursion. And this is how, and you need the reference number to say that, no, this is way below the reference. I'm worried about the function of this part of the diaphragm. But in eventration, you have intact diaphragm. You have a diaphragm to assess. But if you are referring by diaphragmatic hernia, you don't have diaphragm to assess. You have a replaced as a whole. And our experience with this one, what you will be seeing is the kind of the more toward lung ultrasound, because you will see the bowels underneath your probe and not the diaphragm itself, because there is no diaphragm. It's a big hole in this area.
That's really helpful. Do we have any other questions?
Look, I have a question.
Go for it.
Yeah, Adele, thank you so much for your talk. I had a couple of questions. One is, so say if you are looking for diaphragmatic paralysis. So in your practice, I take it you measure the excursion on both the sides?
We do mainly the right side if I'm assessing only the function in a otherwise normal. I'm not expecting paralysis or eventuation. So we use the right side because most of the reference is actually coming from the right side and less reliability on the left side. So even if there is some reference, they acknowledge that the left side is difficult to be sure 100% and give reference now. If you suspect paralysis, definitely you do both sides and you don't have to do any measurement. Once you are seeing the paradoxical movement, the reverse of the normal, this will be your diagnosis. You don't have to measure how this one relates to the normal. Like, is this excursion is like 10%, 50%, 70%. But if you are looking for example, you are using muscle relaxant and you need to assess the diaphragm, then I will suggest that definitely you will not see paradoxical. Either you will see flat line if the medication is like hitting the diaphragm like 100% and knocking off the diaphragm, or there will be some contraction, but very weak one.
Okay.
Like it will be small. Yeah, it will be like small. I received a call. That's why. Sorry for this. There will be a tiny excursion, which is way below the norm.
Okay. Tanno, thank you so much. And I have another quick question. With regards to the diaphragmatic excursion, I know you've sort of shown that it needs to be perpendicular to the diaphragm. Is there any objective measure? So how are you standardizing this in the research setting? I mean, for example, like for blood flow velocities in echo, you have angle of insonation. Similarly, is there something that we can use so that you have
Similar. We have around 20% deviation from the perpendicular still acceptable.
Okay. Thank you.
I agree with you. Sometimes it's very challenging giving the position of the baby and you try to adjust the probe as much as you can. Again, you can't get it the way, remember I was saying this is the diaphragm level on top, your line come in the middle perpendicular, is not that easy to get it this way. So even if you have little bit tilt, you try to bring your M mode again as much as you can perpendicular. 20% deviation from the perpendicular still acceptable.
Thank you very much.
Pleasure.
Any other questions?
Needs lots of practice. Diaphragm, the learning curve for the diaphragm is much slower than the lung. I'm sorry to say this one. So use this opportunity whenever you do lung ultrasound, especially for the thickness and thickness fraction. When you do the R3 or L3, you will be very close to where the position should be. And when you go down to the liver, just look by your eyes to the area of opposition, which end of the lung, beginning of the liver, and above the liver, you will see these two echogenic lines. Try to be familiar by looking at this one. Eye pool, the shortening and narrowing and widening, this is one. And try to put the M mode on this one. It's not easy. And to keep it for 5 seconds, even 5 seconds, the baby will not allow you. I got the two lines, you just bring the M mode on and the baby will move a little bit. Lost. You need to repeat again. One of the challenging one, and unless you practice this one, I will say at least twice per week, it will be very difficult for you to get the experience with measuring the thickness. And not to give you a negative wave, but this is actually was the most difficult part in our studies. Remember, one of the studies that I shared with you is assessing the readiness for extubation. And we did the lung ultrasound score and assessing of the diaphragm both. Doing the lung ultrasound was like a joy, like 1.5 minutes done for the lung, and we take almost 5 to 10 minutes just to get the better view for the thickness and thickness fraction for the diaphragm. Excursion is not different. Excursion is a little bit easier than the thickness.
Any final questions? Any last questions from the group? So I'm going to take this opportunity, first of all, to thank Adel for his time. Thank you so much. That was a fantastic talk. And there's food for thought for us, but there's also more practice, because I think most of our group is getting good at being able to do the structured lung ultrasound using R1, R2 up to R6. But this is more kind of challenge for us as a group to go and practice. And we've got peer review sessions coming up this weekend. That's Friday and Sunday. So I would say, folks, while you're at it, let's watch Adel's presentation again. I will circulate it within 24 hours on the portal so that we can revise, we can have a look at it, and we can actually learn and try and practice. Adel, thank you so much for an absolutely fantastic talk. God bless you.
And I'm happy at any time, Alok, if there is any question or one-to-one from the group, any question, you can pass my email, and I'm happy to address any concerns.
Thank you so much. Thank you, everyone. I wish you a good evening, and thank you all for your patience and your hard work so far. Have a good evening.
Thank you, everyone. Thank you so much.
Thank you. Thank you very much, Dr.
Thank you.